Okay, all right, here we go. So if we can have the next slide, here are my disclosures. They're on my publications, and there's really nothing to it. All this is in the consulting about scientific documents and no research. I want to make the point that I've been concerned about this for a long time. A number of you in this room know who Phil Boffey is. He just retired from the editorial board. And some 35 plus years ago, he quoted me in the New York Times that I was concerned. And I'm still concerned that sodium restriction is not good for everyone. So I'm not piling on. I'm just sticking with the commitment that I've had. And preparing this talk and others, I'm always reminded, next slide, please, of this quote from the New England Journal just about 4 years ago. The administration of normal saline, salt and water, is a basic underpinning of patient care. In many ways, it is more the lifeblood of hospital care than blood itself, i.e. water and salt are essential for sustaining life. Next slide. So there is no discussion, no debate. We all agree sodium is one of the essential nutrients. The human organ requires it for numerous physiologic processes, not just the regulation of cardiovascular function. The organism can't produce it. A definable range for all essential nutrients exists. And the range is usually portrayed as a parabolic or bell-shaped distribution. That range defines the physiological optimal intake. Adverse outcomes emerge when either the lower or upper limits are breached, and we've already seen data saying that's true. Adverse outcomes, though, are greater at the lower end of the distribution because when it's inadequate, the body has nothing but rescue systems, one of which is the renin-angiotensin system, and there are always going to be some long-term consequences. Next slide. So this is a classic slide that Dr. Murch, who was a longtime investigator for USDA, published in 1981. It describes the simple principles of an essential nutrient. If you're on the low side, deficiency, you run into deficient states, and if you get too low, death. If you go to the high side, you get toxicity, and you get death. What is uniformly the case is one of these ends is more precipitous than it is when deficiency occurs than when access occurs. And that is true for the data that exists. A number of you know of our work. The first paper was published in 2009 in Clinical Journal of the American Society of Nephrology. This is the update, and you're looking at almost 70,000 people, all 24-hour urines, 5 decades, 45 countries. All these studies were essentially federally supported across the world. And you have a range of 114 millimoles or milliequivalents to 210. The blue dots represent the second standard deviation. And what you can see visually is a very abrupt cutoff at the lower end and a more attenuated cutoff at the upper end. The organism has ways of dealing with access, not perfect, but access does become a problem. The organism has no way of dealing with something that's too low. This is the same data regrafted by quintiles, and I need not argue this looks like a bell-shaped curve and a normal distribution. We're not the only ones who've seen this. After our first paper, Walt Willett had this paper in American Journal of Clinical Nutrition. As he said, our results for the United States are similar to our first report that I mentioned. And then you have the NutriCode data. This is the survey of both urine sodiums, 24-spot, as well as recall data, sponsored by the Gates Foundation's work on the global burden of health. And it should be apparent to you that if you flip this slide, it would look much like ours. And indeed, when you put our data, shaded dark blue, 1 standard deviation, light blue, 2 standard deviations, our mean intake is 3.6. NutriCode, which Darius Mosafarian used in his 2014 New England Journal paper says is 3.93. Those are the same numbers statistically. And you see the outliers. And you see with the NutriCode data, there's a more abrupt cutoff at the lower end. And we won't go into it, but if you look at the countries that have very low intake, they are sub-Saharan isolated communities. At the upper end, these are mostly Asian populations. This number of 3.6 or 3.9 was actually apparent in 1972. This is a graph that John Lair published, originally describing the relationship between plasma renin and urine sodium. Robert Haney, many of whom you know, went in and redigitized that graph, ran it through a program to get the confidence limits. And as he pointed out to me, where the asymptote of that deviation, standard deviation cross, should predict the ideal optimal sodium intake for renin suppression. It's 156 milligrams or millimoles. And our data says it's roughly 160. That's pretty close, obviously the same. So you see the physiology and the data in humans match up. And this is what we know. There's a consistent 24-hour urine sodium data available if you include our work, NutriCode, 66 countries, diverse food cultures, 5 decades, major changes in the food supply, and demographically representative 75% of the world population. The food supply can't explain this. This is either the real number of what the human organism needs to consume, or it's the greatest fraud ever carried out by humans in medical research. Well over 500,000 people all peeing the same amount of sodium on a given day. You see the range. We know the Asian populations are higher, but interestingly, as Barry Popkin has reported several years ago in American Journal of Clinical Nutrition, those very high ranges in China are moving towards the north. And we can also confirm this lower limit from 2 NIH studies. Next slide. I just want to point out that other essential nutrients have these same type of ranges with a nadir where you have the optimal outcome. This slide has got 4: calcium, vitamin D, magnesium, and phosphorus. Some of them are all-cause mortality. Some are incidence of osteoporosis. Magnesium is cardiovascular disease. Phosphorus, it's also the hazard ratio for death. And you see the same type of curves for all 4 as you see for sodium, and Dr. Youssef pointed out. Next slide. So these are some of the same studies that Salim pointed out. The diabetes study, the heart failure study, which was their original report, and a risk of heart failure from the European Journal of Heart Failure. The green is the zone that we and NutriCode have reported what Willett found. Pink is less than 2,300. Red is the 1,500 that some of them proposed. I think most consumers would know where they would want to lie on these curves. And if you look at Pure, again, the 2014 study, Dr. Youssef pointed this out. Again, the green zone encapsulates the nadir, or the optimal range. The most distressing thing in the Pure data, and this has now been seen in other reports, is what's in Table 2 of that publication that's highlighted in pink here. The lowest risk cohort, and you can see at the bottom, it's all corrected, and this addresses the reverse causality. The individuals in Pure at the greatest risk of a low sodium diet were actually those with the healthiest. And we'll see another example of that later in this presentation. It's not just the people with heart disease, diabetes. It's those of us who are potentially very healthy. So this is a plot that Dr. Welton showed and Dr. Youssef showed. It's from the Cook-Apple-Welton paper. It doesn't matter to me whether you say this is a straight relationship. It is the relationship they showed. But what's interesting is if you superimpose our dietary sodium data in the range that we see people are eating around the world, the hazard ratio is essentially 1 with error around it, but it's 1. So they agree with each other. And you can add the NutriCode, next slide, and its range, and it's the same too. People are eating within the range where the risk is essentially 0. We're close to it. And Dr. Dr. Coswell and her colleagues from CDC published this data 2 years ago in the CDC publication. And interestingly, it's the hypertensives that are eating less sodium than the normotensives. And I happen to think this is correct because, next slide, 30-some years earlier, we published this graph in Science from Haynes 1. And as sodium intake went up, the probability that you had a systolic blood pressure over 160 went down. Normotensive people, or those tending to be normotensive, were eating more sodium than those who had hypertension. The Coswell data from last year, 2 years ago, agrees with what we said in 1984 from the original Haynes database. And so you look at the more recent McMaster's data, and again, the dividing point is, do you have high blood pressure or are you normal? Again, you see the zones green that represent what the urine sodium data from around the world says people are eating. The red is what the current recommendations suggest we should be doing. If you have high blood pressure in that McMaster paper, well, yes, your blood pressure at the higher end may go up. Your risk may go up. But the lower end, it goes up even steeper. And it's also true for normotensives, but at the upper end, you don't see much of a risk. This is the TOPE study, and I show it because TOPE is a superbly designed and an excellent study. There's no disagreement. The goal was 85 millimoles, or milliequivalents a day. The 2 limbs, sodium only, sodium and weight loss. At 6 months, executed at excellent research institutions and skilled staff, they're only able to achieve, on the average, about 110, 115 millimoles is the lowest level. That's the low end that the world population describes. And over the next 30 months, both limbs regress to the mean. This is a complicated study. It's the only randomized, double-blind trial of what happens when you get people down on a low-sodium diet and you give them either 100 millimoles of sodium or you give them a placebo. The study wasn't done to do this. This happened to be part of it. It was done at 8 research institutions. It was guided out of Oregon. It included folks from Indiana, Penn, Cornell, Michigan, South Carolina, and UAB. And the point was, once we got them down to 76 millimoles, which we were able to do using the Indiana protocol that Weinberger developed in the educational material, we randomized to placebo or 100 millimoles. The folks that got 100 millimoles went up exactly 100 millimoles. Those who got the placebo regressed to this lower level of essentially 120. When they flipped, the placebo group didn't go from 120 to 220, it just went up to 176. And the reverse happened. Those who were 176, when they went back to the placebo, They didn't go down to 76. They went down to 120. These studies, both TOPEs and this only randomized double-blind trial, bracket the human intake data. We hear constantly that the United Kingdom solved the problem. Well, there's a problem with that statement that's been reiterated many times. The campaign said the slug started in 2006, but the outcomes compared urine sodiums from 2011 to 2001. They said 40% reduction in food sodium, but when you actually look at the 2011 urinary sodiums published on the Food Standard website, it's a 15% reduction. You reduce the sodium content of food by 30%, you reduced intake by much less than that. The appropriate comparison is the urine sodium data on the Food Standard website, agency website of the UK, of 2006 to 2011. And the website itself says there is a 9% decrease. Next slide, and it's not significant. And here's actually the world intake data and what happened. 2006, you see the mean intake was roughly 154. In 2011, it was 144. Within one standard, that's not statistically significant, and that is what the website of the Food Standard Agency in the UK says, and the references are available. So quickly, what's going on here? And I've made the statement, can policy trump physiology? And the answer to that is no. The brain is a major component of what's going on here. It's controlling human sodium intake, just like it does water, just like it does other minerals and essential nutrients. The red arrows on this slide show that the two primary inputs controlling sodium appetite are angiotensin II and aldosterone, which are the two hormonal responses to a lower sodium diet. How low? Doesn't have to be very low. The Lara data from 72 said as soon as you hit 156, 150 millimoles, you're going to see some increase in the renin-angiotensin system. And the neuroscientists can show, given the techniques that are available today, that if you're sodium deprived, you see the very sensitive aldosterone-sensitive neurons activated, the red dots. If you replete them, they're suppressed. This is not new news. You can go back to 2000, neuroscientists, this is on the next slide, showing that sodium and sodium channels are involved in salt intake behavior. You can go forward to a year and a half ago, investigators from the University of Washington, that these neurons develop an appetite for versus concentration of sodium when the animals are depleted. They will drink something worse than saline when these neurons are stimulated. And here again, they can use the technology of today and show that depletion lights up tracks that then drive the brain to either suppress or increase sodium appetite. So those 500,000 people didn't create fraud and all pee the same amount of sodium. Their brain was essentially controlling some range of physiologically optimal sodium intake, and the outcomes data suggest that. Next slide. So the same thing is going on with thirst. You read about this, many of you, on the front page of the New York Times last week. It was on NPR. That folks at Caltech have beautifully mapped the brain and how water intake. And as they conclude, the consequence of drinking behavior is to maintain internal water balance. Well, water balance means sodium balance too, because we are bathed in saline. This was in Nature just this month. Next slide. These last I'm going to go over quickly. They just show how diverse the impact of either neural or peripheral subcellular function that drives critical factors in human physiology are related to sodium, angiotensin II, or aldo. This is a study 7 years ago in JCI, done Brad Lowell, a gifted researcher at Harvard, showing that activation of these neurons drive feeding behavior. You go to another paper the same year, orchestrating feeding. And this becomes an issue because the data that was published just about a year ago by Tietz and Luft in the JCI is suggesting as you change sodium intake within the range we've described as normal, that you see changes in metabolism, water generation, fat and protein burning. Next slide. And the investigators from Iowa that have been at this for a long time, most of it supported by NIH and American Heart, have published data that as you increase sodium intake, it depresses the efficiency of fat absorption. It's influencing fat intake, fat metabolism, higher sodium being better. And a paper 2 years ago in Cell Reports, these are good journals, these are good scientists pointing out that resting metabolism is modified by the angiotensin A2 receptor. We need to pay attention to this basic science work. This is not just about epidemiology and outcomes of clinical trials. Next slide. JCI paper last year accompanied the Tietz and Luft paper, showing again that the leptin receptors are being controlled or stimulated by the angiotensin A2. So when you go to a lower sodium diet, this is being translated to either the brain or to other peripheral systems that are modifying critical aspects of homeostasis, blood pressure, metabolism, water balance. And here's one of the more intriguing findings from the folks from Humboldt University in Berlin and Vanderbilt, Luft, and Tietz 3 years ago in cell metabolism, showing that, well, you can see, our findings support the idea that salt metabolism is a physiologic component in cutaneous immunological barrier formation and ward-off infection. Salt deposition might serve as an ancient mechanism to aid in immune-mediated pathogen removal. Think about older people admitted to a hospital, lying in bed and infected, all having been on a low-sodium diet, and if they're in a hospital for sure, probably being on a low-sodium diet. Mark Seidel, a gifted nephrologist also at Harvard, Beth Israel Deaconess Medical Center, had this editorial after the paper by Luft and Tietz, and it's made as a comment. The editorial is worthwhile reading. As these pathways become clear, therapies targeted to the control of specific neural networks may be possible and will permit improved treatment of conditions like hypertension, heart failure, and hyponatremia. Hyponatremia. This is the elephant in the room. And it's not been discussed. It's not discussed greatly in the literature, but it's a concern because the pure data has said healthy people are at risk. And as you see in the next couple of slides, other investigators looking at serum sodium levels say the same thing. Because we have the pure data, the Cochrane database, and the Dallas Heart Study have all indicated, after controlling for all confounders, that if you develop a low serum sodium, and we're not talking low, we're talking 138, 137. And here is the data from Nick Medias at Tufts, published 8 years ago. Some 58,000 admissions to St. Elizabeth. First of all, hyponatremia and the CDC data and Haynes data agrees with this. It's the most common electrolyte disorder in the general population. At a hospital like St. Elizabeth, 35% of admissions had a low serum sodium. And that single number, after controlling for all confounders, was associated with up to a 45% increase in morbidity and mortality. And if it worsened in the hospital, look at the increase in your risk of morbidity. And they corrected for, because they had the data. They were younger people and fewer comorbidities. It was not the sickest who suffered this. And there are other studies. The top one is the Medea data from, this is the next slide, from St. Elizabeth in Boston. The middle slide is the data from the Dallas Heart Study. This is an outpatient study of serum sodium and death. And the green bar represents the normal range of sodium, and you can see, again, you would not want to have a low serum sodium. The lower one is the data from N. Haynes, 09 to 04, so that's 3. Next slide. This is data that's unpublished. It's from the clinical trials and the Cochrane database. It was accumulated in full disclosure by my son, Matt, who's finishing up at USC and is doing research. You know, some of you are probably quaking, but another McCarron is looking at sodium intake and heart disease. And you can see that when you go into a randomized trial and you lower sodium intake, you are likely to develop a low serum sodium. It happens in the real world. So the IOM report from 4 years ago, which half the members of the committee know since they were on it, and Dr. Youssef and I were involved in that workshop and in reviewing the report. It's health outcomes. Blood pressure is important, but we have to look at the integrated effect of when you change sodium intake, because it's just not about your blood pressure. And that report said that health outcomes at that time was insufficient, inconsistent to establish harm or benefit for a sodium intake less than 2,300. That statement essentially said we don't have the science to support 2,300. It may be right, but we don't have the data. And said the general population and those at risk should be treated the same. I agree completely. Sodium intakes above 5,000 or 5,500 are not good, and they should be avoided. And we need large-scale, randomized controlled trials of health outcomes. So, in summary, we have to go beyond blood pressure and talk about sodium in health. Sodium's physiologic and cellular impact is diverse, and we have a lot of research needs. Precisely defining sodium's intake's impact on these various parameters are now fair game, because there's enough data in the literature to say we need to be concerned. And that's not just my opinion. There have been other editorials written. This is, next slide shows the title that Clyde Yancey, past president of American Heart, published 2 years ago. The whole notion of sodium restriction in heart failures is now up for grabs. We don't know. The Italian studies, as Paul pointed out, may have been terrible. I don't disagree. But there's a lot of other evidence that we may not be doing heart failure patients the right thing. And the other editorial in the same issue of the Journal of American College of Cardiology and Heart Failure is from 2 members of the University of Michigan cardiology staff, and they agreed. And as Dr. Welton and Dr. Youssef know, this report was published just over a year ago. And the 2 conclusions that stood out, and I might mention there's 2 more Heart Association presidents here, Sid Smith and Suzanne Oberl. Dr. Lufzer, Anna Domenchek, who's the editor of AHA's Hypertension Journal, is there. As I mentioned, of course, Paul and Martin O'Donnell from McMaster. Reduce sodium intake in populations consuming greater than 5 grams. We should all agree upon that. That's not an issue. It's not good. But it's not many people either, unless you're in Asia. It's not many people. It's hardly anyone. in North America, Europe, or most other developed countries. And it called for large definitive trials to clarify the range of sodium intake for optimal cardiovascular health within the moderate to low range. We need to do that. So you can tell my perspective, the DRI for sodium should be based on the current intake data. Until we have other data, that is what human physiology, primarily driven by peripheral signals into the brain, keep the world's population, wherever they're living, whatever the food supply, and whatever their culinary habits, and whatever their age, is dictating. You can't ignore where 95% of the population exists around the world until you have other data, and I have not seen it. As Paul and Salim have pointed out, we need to individually target lowering sodium where it's over 5 grams. There is no disagreement. We agree completely. To me, the biggest priority, it was evident back in 1984 in our science paper. We need to focus on potassium intake. I'm not a gastroenterologist, but I am a nephrologist, and I would say our potassium intake in our societies is not good. And communications need to emphasize foods. Next slide.
David, I'm sorry, we're going to need to move to the next talk. We've got Australia on the line, too. Would you like to make a last comment? Or
yes.
If you can
Put
stay...
the last slide up.
Okay, and I was
the
going to...
last slide just says, okay, it's from John Adams. It's appropriate for Washington, D.C. Facts are stubborn things. Whatever may be our wishes, inclination, it dictates, or our passions, they cannot always state of facts and evidence. Even in Washington, D.C., and I would hope at the National Academy of Medicine. Dr. Stallings, thank you, and thank everybody for listening.
Thanks so much.